All right. So once again, I'm Christina Silcox. I'm the Research Director for Digital Health at the Duke Margolis Center for Health Policy. I have not done any sort of quick change, so I am still a white woman of medium tallness, brown hair, brown eyes, pink sweater. And in this session, we are going to be exploring lessons learned by the Sentinel Initiative from the COVID-19 pandemic. Our speakers are going to present a variety of examples to demonstrate not only what were the key learnings, but also how are they being applied to prepare for future outbreaks. And our panelists for this session are Richard Forsey, the Deputy Director of the Office of Biostatistics and Pharmacovigilance in the Center for Biologics Evaluation and Research at the US FDA, Sylvia Perez Villar, the Senior Epidemiologist at the Office of Surveillance and Epidemiologist at the Center for Drug Evaluation and Research at the FDA, and Susan Winkler, CEO of the Reagan-Udall Foundation for the FDA. And our panelists have each prepared presentations, and afterwards we're going to have a moderated discussion and Q&A. And Richard, we're going to start with you.
Good afternoon, everyone. Again, I'm Rich Forsey with the Center for Biologics Evaluation and Research. I'm a white male. I have blue eyes, short haircut, trim beard. I like to describe my hair color as distinguished, but somehow on all my identification it turns out as gray. So, and I'm wearing a blue suit with a gold tie and a gold pocket square. So once again, thank you so much for the invitation. I'm glad everybody is with us today. There's my disclaimer. I'm going to be talking about how we applied some of the results from our BEST network to important regulatory questions during the COVID-19 pandemic, and in particular as we were trying to figure out what to do with a safety signal that emerged as we were considering rolling out COVID-19 vaccine to additional age groups. I want to start by reminding people of the FDA's framework for conducting benefit risk assessment. So this has been published widely, but we have a framework that looks at 4 dimensions: the analysis of the condition, the current treatment options, the benefit, and the risks or the risk management options. And in the case of COVID-19, we were looking at more than 208 million cases and 4.3 million deaths worldwide at the time that we were considering whether to expand the age groups for the vaccine. In terms of the treatment options that were available at that time, they were really very limited. At that time, we didn't have licensed vaccines or antiviral drugs for COVID-19. We did have some emergency use authorizations that were in place, but all of those were for slightly older age groups than we were considering in this particular submission. For the benefits, we had good evidence from the clinical trials about the benefits of the COVID-19 vaccines in terms of preventing COVID-19 cases, and in particular severe cases. However, we also needed to consider what was going on with the dynamics of the epidemic itself. Because if you are having widespread cases of COVID-19, the vaccines are going to be more important and have a greater benefit than if there's very little circulation at a given time. Then we needed to consider risk and risk management. During the clinical trials, there weren't any notable serious adverse events and deaths related to the vaccinations, but we had seen in the post-market data elevated myocarditis and pericarditis, and Dr. Woodcock mentioned this earlier this morning in her keynote address, that did carry a risk that was important, and the risks seemed to be concentrated in male adolescents. And we considered what some of the risk management options would be, including product labeling, safety surveillance, and post-marketing requirements. So the question that my team and I were looking at was whether the benefits of, in this case, the Comirnaty vaccine would outweigh the risks for ages 16 to 29 years. Mentioned some of the uncertainty and benefits, including the dynamics of the disease, and you'll see that we use different assumptions about that to help bracket those benefits. We had the emerging Delta variant at that time, which caused us to have uncertainty about the true vaccine effectiveness against that new variant. And there was concern about waning of vaccine effectiveness. And we had to balance that against the clinically significant risk of myocarditis pericarditis. In benefit risk assessment, we use a tool called a value tree that helps us lay out what important benefits and risks we're going to consider in any particular analysis. This is the value tree that we developed for this benefit risk assessment. Was focusing on the preventable cases of COVID-19 and more serious outcomes from COVID-19, and the risks were focusing on myocarditis and pericarditis. The main point I want you to take away from this slide is the variety of data sources that we had to use in order to inform this benefit risk assessment. We had to go to multiple different sources, including several CDC sources. We had to use US and international epidemiology studies, and we had to do original analyses in the best data set to help inform us, give us the best possible estimates for the risk of myocarditis and pericarditis. I think most of us in this room are aware of some of the challenges with using real-world data and real-world evidence. In particular, real-world data is not generated for a specific study, and so you have to very carefully consider whether that is fit for purpose. You have to evaluate the, I notice I said fit for purpose. Fit for use is what we are moving to in our FDA language, but fit for purpose is still stuck in my mind. So, we needed to evaluate the suitability of the real-world data and real-world evidence. And we need to use sensitivity analysis in order to help understand how the uncertainty is going to affect our decision making. And finally, we need to acknowledge the remaining limitations. So for conducting this analysis, we designed two major scenarios. There are some additional scenarios, I believe, that are in the published paper, but we primarily did a most likely scenario where we used assumptions across all of the different inputs that we thought were the most likely at the time. And then we did a pessimistic scenario where we chose what we thought were the assumptions that would make the benefit-risk balance look the worst that it could possibly look. And so this was going to help us to bracket the benefits versus the risks. And here are the results for the most likely scenario, and this is per million doses that were administered. So let's begin at the bottom of the bar charts where we have prevented COVID-19 cases versus excess myocarditis pericarditis cases. You can see under the baseline scenario, we were preventing vastly more COVID-19 cases compared to myocarditis pericarditis cases. We were also preventing more COVID-19 hospitalizations compared to myocarditis pericarditis hospitalizations, and preventing more COVID-19 ICU stays, and even preventing a few deaths according to the assumptions that were used in our model. So in the most likely scenario, it's very clear that the benefits are going to outweigh the risks based on the assumptions that were used. In the pessimistic scenario, for the cases, it's still clear that we're going to be preventing more COVID-19 cases than we are going to be causing myocarditis or pericarditis cases. But there's something interesting that's going on with regard to the COVID-19 hospitalizations versus the myocarditis pericarditis hospitalizations. We had two different assumptions about the hospitalization rate. And for the more pessimistic assumption, we were estimating that there might be more myocarditis, pericarditis hospitalizations than COVID-19 prevented hospitalizations. But it was important to note the context here. the hospitalizations for myocarditis, pericarditis tended to be overnight stays for observation, and the people were doing well shortly afterwards. The hospitalizations for COVID-19 could be more severe than that. So when you consider the medical implications, even there we thought that the benefits still outweighed the risks. So based on all of this work, we did ultimately come to the conclusion that the known and potential benefits of vaccination outweigh the known and potential risks of vaccination, even under the pessimistic scenario that we had. And ultimately, the FDA approved licensure for individuals 12 plus in November 2021. So this shows how timely data from these systems can have a direct impact on important regulatory decisions. And there were many people who worked on this, some of whom are actually in the audience today, and our best partners from Acumen and Optum in particular provided essential data on this, and the CDC task force was very helpful for us. And I will wrap up there, and we can have more discussions later.
Thank you so much, Rich. Sylvia, you're next.
Good afternoon. My name is Sylvia. I am a senior epidemiologist at the Division of Epidemiology in the Office of Surveillance and Epidemiology. I'm a white woman. I'm wearing glasses and a black dress. And I'm going to talk today about lessons we have learned to move beyond COVID-19 from CDER's perspective. This is my disclaimer. So specifically, I'm going to talk about some of the contributions of the COVID-19 Sentinel surveillance system, as well as strengths, weaknesses, opportunities, and challenges we have encountered. So early in the pandemic, Sentinel enhanced the common data model by including SARS-CoV-2 laboratory test results. We also incorporated new data sources, specifically outpatient and inpatient electronic health record data, and created a rapidly refreshed distributed database with shortened data lags. We went from 4 to 6 months from a time of care to 4 to 6 weeks. We use Sentinel for multiple activities, including methods development. Some of my colleagues validated diagnosis codes for identifying patients hospitalized with COVID-19 in healthcare claims data. We also contributed to natural history of COVID-19 by assessing the risk of arterial or venous thromboembolism in patients with COVID-19 compared with patients with influenza. As you can see in the publications, we did this for hospitalized patients as well as for patients who were diagnosed in the ambulatory setting. We also, as this study has been highlighted several times today, we also described the systemic corticosteroid use among non-hospitalized patients with COVID-19. When we published the results, this led CDC to issue health advisory, updating providers on availability and use of treatments for outpatients with mild to moderate disease who were at risk for severe outcomes. Of course, we use Sentinel for regulatory decision making. The example I brought up here is to estimate, we use it to estimate the magnitude of the at-risk population using drugs that interact with Paxlovid to inform labeling decisions. We supported other federal agencies. For example, we helped with sample size re-estimation in 2 NIH-funded clinical trials to investigate effectiveness and safety of antithrombotic therapy. We collaborated through the Reagan-Udall Foundation with other US stakeholders, where we shared protocols, real-world data, and generated innovative responses on COVID-19. As also mentioned several times today, we also collaborated with other regulatory agencies through the International Coalition of Medicines Regulatory Authorities, where, among other work, we conducted 2 international meta-analyses, one led by the Food and Drug Administration on natural history of coagulopathy, and another one led by the European Medicines Agency on pregnancy observational studies. This is only a flavor of what we have done. We have done much more, but you can find that information in the Sentinel website. So after all this, so what did we do well? So early in the pandemic, we expanded Sentinel capabilities. We provided recognized expertise in pharmacoepidemiology, led and shaped development and implementation of master protocols, characterized drug utilization and trends, supported regulatory decision-making, specifically for drug safety, and collaborated with multiple internal and external stakeholders. But what prevented us from doing even better? So we had missing critical data elements, so we didn't have data on infecting variant. We had incomplete data on COVID-19 vaccination status, and also it was incomplete capture. We had incomplete capture of supplemental oxygen. Although we improved our timeliness, we still had to overcome data lags, query turnarounds, and proven and clearance processes. Although we had inpatient EHR data from 18 states, we didn't have nationally representative data sources with EHR inpatient data with data on medications. Because we incorporated new data sources at the beginning of the pandemic, initially we had limited experience with them. And also related to timeliness, research was not always in step with a rapidly evolving pandemic. So thinking on all of this, what could give us an advantage to prepare for a future pandemic? So decreased data lag times would really help. To have large nationally representative EHR databases with inpatient data on medications. Further enhancements of the common data model with access to more information. Large EHR claims linked databases, and of course, in artificial intelligence, as you have seen in the prior presentation, some of these opportunities have been already taken care of through the Sentinel Innovation Center, not only in the COVID space. What else? So it could be also a great opportunity to have streamlined and more affordable access to medical records for rapid validation of case definitions for outcome exposures and covariates, data standards and integration, foster the multiple national and international collaborations we have developed, and streamline processes for protocol and study approval, query turnaround, and clearance. So what are the potential barriers that we are going to find to prepare for a future pandemic? So access to complete, reliable, and relevant data, inconsistent access to validated and sufficiently large databases, privacy and security standards, slow development and incorporation of expanded capabilities, competing interests, priorities, the unpredictability of future pandemics, and also maintaining consistent fundings dedicated to pandemic preparedness. So based on our experience of the pandemic, we have demonstrated that we were able to design and implement master protocols and use Sentinel for both emergency response and regulatory decision-making, despite missing critical data elements, not an ideal timeliness, and also insufficient access to inpatient EHR data with medication information. What we see as opportunities for the future is the incorporation of additional reliable data sources, foster all the collaborations that we have created, and it's also very important that if we are able to streamline processes while overcoming competing interests and priorities, leading with unpredictability of future pandemics, and while maintaining consistent funding. I would like to finally acknowledge all my colleagues and collaborators who have done an outstanding work under very challenging circumstances. Thank you.
Thanks, Sylvia. That was fabulous, and I love the infographic on your concluding slide. And next up is Susan.
Yes, Sylvia, we might all borrow that infographic for the strengths and weaknesses and opportunities. So I am Susan Winkler, and I serve as CEO at the Reagan-Udall Foundation for the FDA. I am a tall white woman in a green taupe and black leopard dress with a black jacket. I have short, dark hair that my children would tell you is more salt than pepper. So I'm going to talk a little bit today. It's obvious what FDA did during the pandemic as it related to real-world data and real-world evidence, and it may be less obvious what FDA's foundation did. And so much of our activity was built around a group that we convened on a weekly basis, the COVID-19 Evidence Accelerator, where we aspired to gather the real-world data community to talk about what we were learning about COVID-19, then what we were learning about the data flow as it related to drugs, biologics, and diagnostics, and to interrogate that data and say, what did we need to know better? How might we improve what was happening in the community? And I think just generally provided a community for the researchers and those who were working on these activities to ask questions and bring different topics forward. So what I'm going to share are a couple of things that we learned through that Evidence Accelerator experience, as well as some work that we're doing to address those lessons learned. So one of the main lesson that we learned is that we can and we really have to improve the collection of real-world data to then power the real-world evidence that we generate. And so I'm going to talk about some of those real-world data weaknesses identified and the implications, and then efforts to improve that. So what we haven't yet talked about in our session, but it came up in the last one, and there's some inconsistency in how data flows. And this is based on the flow of diagnostic testing information. And what this infographic shows at a high level is that there's a fair amount of diagnostic testing information that, at least in the pandemic, didn't ever make it to any EHR, didn't show up in a claims database, and was really probably only known by the individual and their family member. And so there's just some of that reality that there is a fair amount of information that does not ever reach the EHR. And sometimes that matters, and sometimes it doesn't. But if we think from a testing perspective, it can matter if we're looking just generally about the performance of those tests. So then we get to, if you think, well, at least some of that information flowed to the electronic health record. When it comes to diagnostic test information, what flowed to the health record was the result of the test. What rarely flows to the record is the test that was used. And so there is an assumption of parity of the performance of all of those tests. And if any of our colleagues were here from the Centers for Devices and Radiological Health, they would share that, in fact, that assumption is probably wrong. and in fact, we wouldn't know it. We shouldn't assume it. So there is this gap that we don't know what test was performed, and that can become important when we're looking at the data that's generated. And in that, it simply generates those assumptions that the quality and the consistency of the testing is equal, which really starts to kind of shake the foundations of what we're thinking about in that diagnostic result. So it did still yield good evidence upon which we did a lot of good work, but we could do better. So there are efforts now to better capture the information so that you know what test was performed, that then allows that better review and understanding of the performance of the different types of and specific lots of diagnostic tests. So we can do better there, and there are a host of efforts that are trying to improve that collection of information about tests that are conducted. There was a second place where the data was simply not as rich as we would have wanted, and that had to do with race and ethnicity data. And so and if we think about the fact that it was it was really important in our understanding of COVID-19 and then the burden of disease that was on our traditionally underserved populations, in a number of places, race and ethnicity data is missing. And so we simply don't have that information upon which to then generate a better understanding of what's occurring there. So that's one where we can do better in gathering that information. We can do better also in our curation of that information. There are some, at best, well, for certain, there are inconsistencies in how race and ethnicity data is collected across systems. And then there are inconsistencies in what's done if you have different reports from different data sets. And race and ethnicity data, another piece that we've learned through a project that I'll talk about in a minute, is that race and ethnicity data actually can change over time, in that what individuals will report about their race and ethnicity depends a significant amount on their trust in the entity or the individual who is asking about it. So that yields then sometimes where you have an inconsistent reporting, and we have to think about how you deal with that inconsistent reporting. Some have just said, well, if I have inconsistency, I'm going to call it multi-race, which in a way just took away any helpful information that you had and said, we have a mix, which is less than helpful in trying to navigate that. So this was an example of where we can do better. So I'll just touch briefly on a project that we are just wrapping up with a different part of FDA that was intended. It has a very long acronym, as we must in doing so much work with the FDA. But the goal here was to improve the collection and curation of race and ethnicity data in healthcare. And so we convened a group of conversations in the evidence accelerator model of health systems, of payers, of folks who are gathering real world data, to have a conversation about how might we do better at collecting race and ethnicity data. What can we do better in curating that and integrating it so that we have a better data repository to be used to generate real world evidence? And those conversations yielded a number of different things and in helping us to explore and say, how might the systems, the payers do better? How do you overcome that hesitancy on the parts of data collectors to gather the information, the hesitancy of individuals to respond? And then how might we do better in standardizing that, in protecting the privacy, and helping communities understand what they're sharing and the value of that. So I'll just note that there we've been gathering the community and talking about how we might do better, and have generated what will be a roadmap to engage communities and helping to improve that collection of race and ethnicity data. So Christina, what we tried to do there is say, we took actually the approach that Rich and Sylvia did of the strengths, weaknesses, opportunities, and challenges, and say, here's some things that we're trying to do that we hope at the end of the day will yield better population of at least race and ethnicity data in real world data. And so that's our quick tour. I will turn it to you.
Thank you so much. These have been a fabulous set of presentations. I really appreciate it. So we heard from Rich. We heard, kind of walking us through a decision tree and how to not just kind of take that at face value, but dig into some of those comparisons as well. A really interesting way of thinking about it. From Sylvia, we heard about multiple studies and some of the support that you all did, both in the international sense, national sense, NIH, other types of spaces, and then a great list of where you think things went well and where there are maybe some more places to go. And then Susan, a great presentation talking about how we need to think about how to improve real world data collection, particularly thinking about how do we be more specific about medical products, as well as better describing people, and making people more comfortable with that descriptions. So this has been a great panel so far. I do want to encourage everyone again to use Slido. You have the QR code right there. You can also go to slido.com and then push hashtag Sentinel in the little box and go ahead and submit your questions. I do have a couple of ones ready for you. So I'm going to start with Sylvia, but I do want to ask the entire panel this. Given the magnitude of COVID-19 lesson learned, how are you anticipating prioritizing the building new capabilities? We have big lists, and just from this panel, and I know there's a million other panels happening where we're trying to figure things out. So how do we think about prioritizing?
So basically, I think that if we have to deal with a new pandemic, we will need, again, to understand the disease, the impact of the disease, identify the high-risk groups as soon as possible, and also to be ready to assess the safety and effectiveness of the products that we authorize under emergency use authorization. So I guess that for that purpose, I would prioritize to have deep knowledge of the catalog of databases that we have available, understand exactly what we can do, what we cannot do with them. Ideally, they need to be large. They need to be nationally representative. And also, I think another key element that we have learned is the pandemic doesn't wait. So we need to basically improve in timeliness. We need to quickly provide robust data. So.
And I thought one of the points you made in the presentation that was so interesting is being able to predict what questions are going to be asked, not what questions are being asked now, which I thought was a really insightful point too. I think to kind of what you just said. Susan, I want to throw that question to you as well.
So, there are many conversations, right, and have been many conversations, and then a whole lot of people have moved on. So I think part of our prioritization is in that collaboration and communicating about who's doing what. And that we will probably need to, in 12 months or so, assess and say, okay, how does what's being done compare with what we said needed to be done, and what does still need to be done? So maybe it's a discipline in sharing who's working on what in those improvements, and then checking in so that we don't end up, accidentally leaving behind things that we thought were essential to pursue.
Yeah.
And then I think just having, Rich, I have to mention, we also have to figure out, it won't be on anybody's official list, but we should figure out how to respond to armchair epidemiologists and communicate, right, what goes into the discipline and the ruthless transparency of digging in and actually answering these questions.
So if I could, I'll just build on what both Sylvia and Susan have said, and those are great observations. I do want to start with the armchair epidemiologists. So obviously there was a tremendous amount of interest in the pandemic, and lots of people made observations. Some were actually quite helpful. There were some people who, outside of government, who were actually doing really helpful communication, and I want to be sure to acknowledge that. But building on some of the data needs, I'm going to build on what Steve Anderson discussed this morning about the need to integrate. And my mind first goes back to the very beginning of the pandemic, when we didn't have codes for COVID-19 cases. Right. And originally those codes were going to be available, I believe, on October 1, 2020.
Because that reflected urgency in the process of development. Yes.
But I will just say, everybody recognized that was an issue, and we got moved up 6 months, and that helped a lot. We also worked very hard to get the codes in place with the necessary specificity for the vaccines, and we were patting ourselves on the back about that, and we thought that was great. But then we saw that a lot of the vaccinations weren't showing up in the claims data because nobody was filing a claim. And that was when we realized, okay, we're going to have to do another step. We're going to have to reach out to the state jurisdictions to work with the immunization information systems. So I think there's going to be surprises. I think we can prepare to be nimble in future pandemics, and just getting the core information that we need to conduct the analyses is a good place to start.
Thank you. And I think that, I'm not going to answer it right now, but I'm just going to throw this out there, because I think one of the things I heard from all of y'all was that there's a lot of this stuff happening and people don't always know. And so how do you kind of actually, I'm going to go ahead and ask this now that I've already started thinking about it. How can we do a better job of understanding what efforts are available, what infrastructure already exists, as well as understanding who's already working on certain questions and how, and so that we're not duplicating efforts?
Mm-hmm. Well, we probably have to start with a culture of candor that we don't always have, and in trying to cultivate that so that we're willing to share who's working on what, and willing to share what questions and challenges folks are seeing versus always just talking about, well, here's what we did really well and how things. So I think it's part of it's that culture piece, and then it's meetings like this and probably a more back to the discipline of the reflection that we say, okay, what did we say we would do? Are we encouraging that sharing, and then are we reporting out that sharing so that others want to make sure and add to the repository?
Great.
One thing that I really noticed was that the pandemic, in my opinion, seemed to accelerate the use of preprint communication of results. And I think that was something that was really important during this. And there's other ways to quickly get information out that don't necessarily rely on the full peer review process, which is critically important. It has to happen. But when things are moving as fast as the early stages of this pandemic, there needs to be other ways to get that information out.
Mm-hmm. Yep. Yeah, and a lot of advantages of preprints anyway, in understanding what people are working on, how they're doing it, things like that, so that so as you're designing new studies, you can think about what's already out there. So I think, I think that's really key. While the exact nature of the next pandemic is not knowable, how can we think about systems like Sentinel, like BEST, like some of the work that Reagan, you all do, to be kind of set up to more quickly understand the nature of the next pandemic? What can we do now to be ready? And Sylvia, I'm gonna start with you on that.
So I think that, of course, as I said before, I think it's very important that we have data that we understand properly, and we have outpatient, inpatient, ICU admission data, and we also have a good linkage to the to death information. I think that this certainly will help us to quickly run analysis to notice different changes in patterns in regard to medically attended visits, hospitalizations, deaths, or ICU admissions, etc. So I think this is one of the basic considerations I can think of. Also, so I think that also to follow, so basically to monitor as we often do, basically shortages, to observe whether there are medications that are used more often than they should, there are shortages, etc., that can serve us as well as a potential basically signal to for us to identify something that might be happening. So yeah, I think that more or less would be
perfect. Rich, do you want to add anything?
Yeah, I agree with what Sylvia said. I'm going to go in a slightly different direction. I think one of the things we need to do before the next pandemic is work hard to rebuild some of the public trust that has eroded during all of the contentious discussions around COVID-19 and the vaccines and treatments that were available. So I think that we need to make a conscious investment there in trying to figure out ways to rebuild some of that trust.
Yeah. And if I could piggyback on that, I think it's the trust in science. So are we better communicating? And then in science that we share more about being more humble in communicating that, right? One of our challenges in COVID-19 was that in a desire to be confident and dispositive and providing advice to everyone, we forgot to say, and we're still learning a lot. So the advice might change tomorrow. And so it created distrust in an environment where I think many of us knew what we were saying in March of 2020 was probably going to change as we learned more, but how do we help strengthen that? The trust piece also goes to what I was talking about in strengthening the collection of real world data. It's an opportunity to help individuals understand how their healthcare data is used, and therefore why they may want to share it. Because I think we will continue to see we have trust deficits in the healthcare system, and that affects not only the care that is provided, but also then the data that is collected. And there are just many trust deficits that if we could bridge or close any of those gaps, will help us from more than a data perspective.
And Susan, if I could just real quickly build off that.
That's fine. No,
But I think your last point also goes to some of the health equity issues that were raised during your presentation, because the trust deficit is not evenly distributed across everybody in the country. So we have to consider that dimension as well.
And I actually want to build on that as well. There's an audience question. I'm going to ask the audience question and add a little bit on, because I think it relates to some of the RAISE project work that you were talking about, which is around collecting data that patients are concerned about giving because they don't necessarily see the relevancy. Right. And race and ethnicity is part of that, but also, and this question from the audience is around geographic distribution, location, and also income. And I'm going to just build on that and say other social determinants of health. How do we, help patients kind of get the trust that they need to be able to disclose that information? When should we be asking it, maybe is one of the questions. How do we make healthcare providers more comfortable asking those questions, which is one of the things that you had pointed out. But I think it also, kind of along with that trust idea and the education idea, can we talk a little bit about how that data then is used in some of the analyses? So I'm going to start with you, Susan, if you can talk a little bit about how we collect this data in a more trust-filled fashion, and then maybe turn to Sylvia and Rich and talk a little bit about how that data is then used to help analyses.
So the when and how is incredibly important, and I should shout out Carla Rodriguez-Watson, who's our principal investigator for the project, is in the back of the room, so I know she's going to shout me down if I have not gotten it quite right. But one of the core parts of the RAISE conversations was that you must be intentional in engaging the community in an enduring manner. That it's not simply kind of coming in and saying, okay, we're going to do better, and then moving on to something else. It's having the conversations, and so it's the when and the how, and providing some of that why, and then also thinking about what are some of the populations who we don't even see in our current data collection. If it's the difference in sex and gender identity, we just don't see transgender individuals in data today because it's not collected in any way. So it's about doing this with community, so with patient and consumer input, and which then I think provides the opportunity for individuals to share their information so that they know they would be represented there, but also understand how it would be used. And then we also then have to provide some of the control that's inherent in HIPAA if they don't want it to be used, that we observe that and give not only lip service to that, but truly honor that preference.
Makes sense. And I think we'd love to hear a little bit about how some of that data is used to better understand pandemics, how we use it in COVID-19, and how we might do it in a future pandemic. Thinking about both race and ethnicity, but also about geographic location and socioeconomic data. So I am happy to start with either one of you.
Okay, I'll go ahead and start because we, in some of our projects, we have used a lot of very granular geographic data in order to help reduce some of the potential biases in our data. And we also have used it in analyses to, for example, chart the spread of other epidemic diseases. Babesiosis is an example where we've looked as the geographic range of babesiosis has spread. But specifically with regard to some of the social determinants of health that's referred to in part of that question, we use a measure called Area Deprivation Index, which helps to describe differences in income, access to resources, a wide range of factors that can be calculated at very high resolution geographic areas. And we've been using that to control for some of the differences in some of the analyses that we have conducted. And so again, I think this goes back to the notion of trying to find ways that you can integrate information from multiple data sets to get a complete picture of what's going on. So we have to link into a bunch of census data, map it over to the geographic location of the beneficiary, and then build that into the model. So we've done a lot of work in that area, and we think it's really important.
Thank you.
So in regard to Sentinel, I didn't mention that, but I put that in one of my slides. One of the critical data that we also found that was missing in the Sentinel system when we use claims was race and ethnicity. It is true that through our work through the Sentinel Innovation Center, we are able to link EHR data with claims, so we are working on solving that issue. And also, and the other question was
so the questions were around how geographic and socioeconomic data
geographic,
might be used.
yes. With geographic location, when we work with Medicare, yes, we are able to basically use very, very granular information in regard to geographic location. When we're using Sentinel for privacy concerns, we are a little bit more limited, but it is true that if really there is a strong reason for that, we are able to go beyond what is basically in the standard system.
Mm-hmm. So thank you. I think that was really helpful in thinking through kind of why is it important to collect this data, and understanding how it's going to be used makes it really important. I do have another audience question which asks, each hurricane season we have a list of names ready to go. Would it be possible to have codes on standby for future pandemics?
Sounds like a good idea.
I mean, were there dummy codes that could be used kind of in the meantime? I will say that I did hear that there was some creative coding being used until there were real codes, using kind of disused codes and things like that.
Right. Well, because you had not only the ICD, the diagnosis code gap, but also some of the drugs made available on emergency use authorizations didn't come with NDCs, and so you had different. They were spelled in creative ways too. It's an intriguing idea that you have the codes.
All right. Well, see, the audience is coming up with great ideas. All right. Now, did I hear that we might have an audience question from the room?
If anyone from the audience does have a question, we've certainly got a mic for you.
All right. Well, while we're waiting for someone to be brave go ahead.
Hi, everyone. Krista Schrader, Eli Lilly and Company. So I put mine in the chat, but I do not mind reading it so that it gets asked. So I know we were talking about getting information out very quickly and these preprints on papers, but I remember there being a lot of struggle around that with the withdrawal of papers and, creating distrust. And so I wonder how we find a balance, in getting information quickly with, yeah.
So I'll note one of the early conversations in the COVID-19 Evidence Accelerator was some chatter about, I'm really surprised that study said that, and it was part of that kind of community applying some ruthless transparency and criticism, and I think part of it is the discipline and the way we approach the work, and say that speed is less by cutting corners and more by the more people involved and moving forward. I think it's that we have to continue the conversation and the interrogation of the information, and not short circuit any of that interrogation and tough questioning. And then there will be, again, and then we'll learn things and perhaps explaining, okay, this is what we thought based on that, and here's why we think something differently, which takes more time than simply kind of dropping the first and moving to the second component. But you're right that in seeking speed, we can't sacrifice the quality and the rigor.
Yeah, it's a real challenge. I do think that part of a longer-term solution there is better explaining to the public, and perhaps starting with the science writers in the media, how this whole process works, so that and Susan, this goes back to your point. We want to come forward and we want to give advice that people can act on. We don't want to list all of the disclaimers when we're trying to get an action, but maybe we need to. Again,
well, even something as simple as based on what we know today.
Yeah.
Right, and reminding because for the general public, the idea that it was a novel virus, even just saying novel virus doesn't communicate what it is they needed to know. It was, we haven't seen this before, and so we're we're working really hard to understand it, and based on what we understand today, here's our suggestion.
Yeah. Another question from the audience.
Yeah, thanks for a very nice presentation, all of you. Rich, you mentioned something interesting when we promoted with CDC to accelerate by 6 months the use of the COVID code, and then when we work with Michael Menis and Jeff Kellman together in trying to get granularity on the vaccination code, and then found the disappointing news that when we tried to use the data, particularly very early in the data, when vaccination was distributed through community centers, states, local health departments, there was no linkage to the insurers. How do we resolve that before the next pandemic? Because we were, our hands were tied there.
Do you mind introducing yourself?
Oh, sorry, Hector Izurieta, Food and Drug Administration.
Thank you.
Well, I'll speak with the clarity of 2020 hindsight right now. And I think going forward in the future, the federal government was providing all of those vaccines. I think it would have been possible for us to say, when you administer these vaccines, you should report it to the patient's health insurance company, and so maybe anticipating in the future the need to make sure that information gets back to the health insurers is something that might work. But let me be absolutely clear. None of us thought of that at that time. We thought people were going to be charging for the administration of the vaccines, and that those codes would show up and all our problems would be solved, and we were wrong about that.
Yeah, but I bet I'll just predict, we might have seen the last of the paper cards. Right, I mean, good gap filler, and then let's do better next time.
I will admit the pharmacist was surprised when I brought my little paper card for for my booster last month.
I think I have 3 in my wallet. Right, I just keep stapling them together.
Yes, please.
Hi, Heather Rubino from Pfizer. I used to work at a state health department, and so my question's going to be from that bent. So, at least one of the things that I know from having worked in public health is that good surveillance and good response and good communication needs to come from the local level, and it needs to come especially when we're talking about disparities, to have the cultural competency to speak to the people in a way that they'll listen, that builds trust. So maybe you could tell us a little bit about what the development steps are for building that capacity out before the next pandemic. And as a respiratory disease epidemiologist, there is a next pandemic. It's probably avian influenza. Thank you.
Thank you.
So CBER engaged the foundation to do a project in fall of 2020 to go out to underserved communities and just say, what do you think about a COVID-19 vaccine? It doesn't exist yet, but what do you think about that? And that provided really helpful information to then on 2 points. One, it allowed us to identify the questions that were most likely to be asked and develop responses to those questions that would be well received. It also, probably the greatest thing that it exposed was it was going to be important to provide space for people to ask questions. And that it's the declarative of, oh, we're going to have a vaccine and you should get it, works for a portion, and then we have to really bring along and educate and doing it in a culturally competent way. So I think we need to continue to invest in listening to listening to all, and we certainly have to continue to invest in the infrastructure of the state and local health department. That I think that's maybe one of those lessons learned that we've already forgotten and are not having the sustained investment that we really need to have. So I don't know that we got an answer there, Heather, other than it's of interest.
And I'll just say one of the things that I personally learned was that the local public health groups go through boom and bust cycles all the time, and it's terrible for them to be able to plan to build capability. So it's something to consider.
Mm-hmm. And I think trust and communication is local, right? So it's going to be very hard to build any kind of one-size-fits-all solutions. What you can do is build an education for people who don't understand the mistrust. Mm-hmm. And then I think that that's actually almost more important, because I think that the solutions for how to build the trust are going to have to come up from a local ground roots type space. Mm-hmm. Mm-hmm. But we need to make sure that people understand the importance and that it's not actually there.
Yeah. And we have a huge job ahead of us with where we're at the moment. So we have a lot of work to do.
We
Yeah.
have one more question in the back if we have time.
Yes, 2 minutes.
Okay, perfect. In the back.
Hi, Michael Perry from ServiceNow. I had kind of like a twofold question, unrelated, but the concepts for tracking and rigor apply. The first question is, you mentioned about kind of rebuilding public trust. I guess my question for that is, have you thought about or are you already kind of formalizing a plan to like track that in any specific way? So like, here are the 15 top public negative sentiments. Here are the things we're going to do to combat that. Here are the different campaigns we're going to do, and kind of attach the work to what needs to be done to kind of mitigate those. So that was the first question. Second question, completely different domain, but same kind of concept with applying rigor to that. You mentioned earlier, it was mentioned earlier about kind of prioritizing enhancements to the different systems that you're using, ARIA and the different gaps and all those kind of things. Do you have an official way to kind of capture what those gaps are, the impacts of those gaps, and then prioritizing the enhancements and kind of formalizing a roadmap over time on how to make those?
I can do the first question really fast. So the foundation we issued a report to Commissioner Califf a month ago on strategies to improve public understanding of FDA and FDA regulated products. So the short answer is, I'll get that to you.
Yeah, and again, I think it's the first question is a fantastic question. It's probably not what my group does. So we have to find the right people to work on that. But I agree, it needs to be done. As far as the Sentinel sufficiency and what ARIA can and can't answer, well, I think we saw some of that today about the advancements that are being made and how they're able to address more questions. I'll let Sylvia, if Sylvia has any final comments on that.
Yes. Trish, who is going to present later, look at the area assessment that we, the reviewers, conduct and identify specifically in which elements are lacking. And there is, as you saw in the prior presentation, there is an effort now to try to address those elements that we cannot use or we don't have yet, because we really want to be able to make ARIA sufficient, at least for most of the PMRs that we are issuing. So we are, the answer is yes, we are actively working on that.
Well, thank you, everyone. I would love to give the panel, again, just a huge round of applause. Really a great discussion. I really appreciate it. You guys can go ahead and then thank you all for staying for the next session, which is going to be run by my colleague, Trevin Locke. He is an assistant research director here at the Duke Margolis Center, and he will be moderating our final session. And there's just going to be a moment while we are getting microphones on.
All right. Hi, good afternoon, everyone. As Christina said, I am Trevin Locke, Assistant Research Director here at the Duke Margolis Center for Health Policy. I am, you can't tell I'm sitting down, but I'm a relatively tall white male in a dark gray suit. And I'm very pleased to be moderating this final session of the 15th Annual Sentinel Initiative Public Workshop. I think we have a very exciting panel ahead, so thank you all for sticking out to hear from a variety of stakeholders on kind of where Sentinel has come from, where it might be going as we head into the future. We've got a diverse array of perspectives from patients to data companies, professional societies, industry, and of course, FDA. I'm going to head into our panelists in a minute to give some short remarks, but first I'll introduce everyone. I am pleased to be joined by Heather Rubino, Head of Safety Surveillance Research at Pfizer, Philip Goodney, who should be joining us on the screen as Vice Chair of Research in the Department of Surgery and Director of the Center for Evaluation of Surgical Care at Dartmouth College. Anna McAllister, a patient advocate with a focus on patient engagement and data use, access, and governance. Jeffrey Brown, the Chief Scientific Officer at TrinetX. Patricia Trish Bright, Associate Director and Sentinel System Lead at FDA. And finally, Steve Anderson, Director of the Office of Biostatistics and Pharmacovigilance at the Center for Biologics Evaluation and Research at the FDA. As I said, we'll begin with some initial remarks from our non-FDA panelists, and then we'll follow up with our FDA speakers, and then we'll finish our time with moderated discussion and Q&A. So Heather, I believe we're starting with you.
Hi. So I'm delighted to hear so much conversation today about the ways that we can generate safety insights faster. I think it's worthwhile mentioning that we should also think about which safety insights are able to be generated more quickly and getting those data out in a more consistent way. I heard the previous panelists speak a lot to knowing the data and having a deep understanding of what those data systems are and not waiting until there's a next pandemic to understand those. So I think what we're really excited about in industry is the way to generate those safety insights faster, to really focus ourselves on patient safety and not just focusing on product safety. So that's identifying signals if they occur, but also being able to quickly answer questions for when signals may not be true, to be able to open and close as needed with an answer of yes or no. The next thought that I had is one from being a surveillance epidemiologist background. And it's that in this pandemic, while we've seen 20 years of investment in infrastructure to turn huge amounts of data around quickly, the first insights for safety around our products, particularly in the COVID-19 vaccine, wasn't from secondary data sources. It was from primary data collection. I joke that this is the old ways are new again. And I think one of the things that I'd like to see further development from data partners on are ways to bridge primary data collection measures with secondary data collection and really focus on the pieces that are the strengths of both of those approaches. I think this could have particular importance for the social determinants of health, where people might be more comfortable self-reporting their own race ethnicity data than us trying to tease out what is self-reported versus reported from a healthcare practitioner making an assumption about the race or ethnicity of a patient. So, and a brief description,
please,
right?
Thank you.
That's
Yes.
what I missed. Hi, everybody. I am a white person with short hair, red turtleneck sweater on, and lots of freckles.
Thank you so much, Heather. Jeff, we're going to go to you next.
All right, thanks. So I am a white male with a blue blazer, average height. I'm told average looks in my family. So I'm bringing maybe a unique perspective. Until 2 years ago, I spent 13 years at Sentinel in the operations center. So I was there for the very first call that I got, can we do this? And I remember exactly where I was and when it was. And that was very early in Sentinel. We built something, there's a question, do you think we can actually answer it? It was my 4th of July holiday and my boss still called. But the answer was, yes, we can. So, but that was a long time ago. So I was asked to think through some successes and then future. So just what's Sentinel been doing, and I framed it as successes, and then where to think about the future. Maybe most importantly, I think Sentinel really changed the conversation to, is it possible, to why aren't we doing more of it? And I think that's really, really important. Janet mentioned it this morning. I can tell you when the first contract was signed, not a lot of people thought it could happen. And we're seeing that success, and I think that success bred success of other networks. So you see networks in Europe, there's other networks in the US. It's no longer is it possible to do, it's really about what else can we do. In fact, so I should mention, I'm now the chief scientific officer at a company called Trinetics. Our original business plan 10 years ago mentioned Mini Sentinel and said, you know, these federated networks can work. And that generated a company that's 10 years old, doing global, we have a global federated network supporting clinical trials primarily. And I'll go with full circle. Trinetics is now supporting Sentinel, right? So it generated the interest and opportunity to build something, and now what our company built is now coming back to try to help support it. So I guess that's nice full circle. I guess I should make sure we mention, Sentinel wasn't the first distributed network. There were others. Vaccine Safety Data Link is probably the oldest. There were networks, the Cancer Research Network. Kaiser did a lot of this early work. There was actually a pandemic, an H1N1 pandemic, where there was a network built. There was a distributed network built. We linked to immunization registries. It was very hard. But there's other things that happened here, and I think Sentinel has built from those experiences, and now others are building from it, which I think is really important. There's a whole set of advances I think that Sentinel has made in federated analytics. Fit-for-purpose data analysis is actually really incredibly important. Not all data sets can do everything. You have to understand what they can and can't do. I think it's actually important to think through the collaborative approach that Sentinel and FDA took in building the network and how that's helped others. Meaning there wasn't a knock on the door that said, please send me all your data. I super promise we'll be good with it. So there had to be a technical approach. And that was one of the options. I was back then. And that's not the approach that was taken. And it was a more, I think, a more thoughtful technical approach that treated all the participants fairly. And I think that really helped foster participation in the network. Janet mentioned this morning also the space of signal refinement. So there was a time when there'd be signals would appear, no one knew if it was true or not, and it would just end up on the label, because what else are you going to do? Now there's a way to think it through and to do that assessment, and that's incredibly important. I'll take the last couple, maybe minute or so to think about the future. So I think that was my thinking about how Sentinel's really helped. Maybe I'll go down what I'd like to see happen. Right now I'm on the outside. I can just ask other people to do important things. So routine signal detection, I think, is important. It's probably not relevant for every product, but there are likely products that meet certain characteristics where we should just be doing routine signal detection. It's scary. Darren showed a couple examples of pilots earlier today. We think it can work. That should be something that we just routinely are doing, using the network to do. Routine active surveillance, same thing. Probably not every product. There's lots of characteristics of products you might want to think through, but it shouldn't be one-offs. We should be thinking, new product, how do we surveil? What are we going to do here? And I would like us to be saying yes instead of no first. I want us to be saying yes first, and then why not versus no, and have to think it through that way. Maybe some rapid fire so we can keep moving. The phenotype work is actually incredibly important. Jen Nelson was talking about it, and the Innovation Center is doing that phenotype work. That helps everyone. If you develop a phenotype, everyone can use the phenotype. That means FDA can use it, and CDC can use it, and pharma can use it. Those phenotypes, we shouldn't be all doing them all at the same time. I don't think that happened during COVID. We could have coordinated that much better, I think. I think Sentinel's doing a really nice job on expanding to new data sources and to other data sources. But I think there's a risk in, I'll go the opposite way. It is important the way Sentinel has disciplined to keep a diverse set of data sources. FDA could have checked the box with 2 data sources and said, I got 100 million people and we're all set. They didn't. They really actually were very thoughtful about how to build the network with the data sources and those collaborations. But it's important to maintain them. It doesn't mean it's always going to live that way, but I think it is important. And actually, John Seeger was talking about it when he was like, the connection between his epidemiologist and that data is a critical link. And when you lose that link, you lose value. And FDA didn't lose that link, and I hope they don't. Let me put it that way. There's probably a fair amount we can do in special populations. So that could be pregnancy, race, ethnicity. There was talk yesterday, I don't know, it was in the news about clinical trials including obese patients. Well, surveillance should also be able to include obese patients. It's really common for clinical trials to not include BMI over 30 or 35 or something. But Sentinel can include those patients. We should think through public health registries and how our public health, I would just say FDA is a really important stakeholder here. FDA is not in charge of the state registries, birth registries, death registries, immunization registries, cancer registries. But boy, you could really make use of those data if you could get your hands on them. But how do you do that? That's through linking and partnerships and things. So how do you work that through? Boy, National Death Index. It's actually hard to know if someone's alive or dead in these data. And that's really not, that's a problem. And that's not because FDA doesn't want to do that. It's because it's a hard ecosystem to work through. So, but it's something that we can work on. And I'll just mention at the end, it's expensive. So no one else asked me to say this. These are expensive systems. And it takes a real investment to keep them alive and keep them growing. So I get to say that now that I'm here. But it's true.
Thanks so much, Jeff, for those great insights. Next, I think we have Philip ready to go on the screens.
Hi, thank you very much. My name is Philip Goodney. I'm a 5 foot 8 inch tall Caucasian male who's wearing lead in clinical attire. I take care of patients today, so I apologize for not being there in person. I've enjoyed hearing much of the panel. My comments will be brief. I've enjoyed hearing a lot about linked data sets because this is close to our heart. I'm a vascular surgeon. Clinically, I do arteries, operations on arteries and veins and implant devices in many of those settings. And making sure those devices work in both the short and the long term is a critical element of surveillance and often difficult to do without distributed data networks. And we're fortunate to have, for the last decade, to have had linkages between our clinical registry, which has over 1 million patients treated with different devices for vascular disease, linked to both Medicare claims as well as several other state-level data sets, as well as validated algorithms to look for late events, like how long did the patient live afterwards? Did they need another operation because the device might have failed? Did the device do what it was supposed to do? So for example, did the device prevent rupture of an aneurysm? And has the patient been getting their appropriate surveillance? Because all those events, whether it's a CAT scan image or an operation or rupture, fortunately are billable and fortunately have codes attached to them. We've had a very collaborative relationship with all the providers who perform these types of interventions, surgeons, cardiologists, interventionists. We've been supported by FDA, and we've built the network to basically provide this surveillance in real time. So we call this the LEAF, or the Long-Term Endovascular Assessment and Follow-Up System, and this provides biannual reports back to our corporate partners, the companies who make these devices, for the real-world data assessment of their devices in practice. And we just issued the first of those reports on November 6th as part of this collaborative project. We had provided these reports to hospitals and members of our QI initiative for more than a decade, but providing them to industry and partnership as a mechanism of real-world evidence surveillance is, I think, truly novel in the cardiovascular space. And we're fortunate I'm pleased to show that it's up and running. So I'm excited to hear of so many other interests in linked data sets for diversified and distributed data networks, and happy to share any other information about our efforts. So thank you.
Thank you, Phil. Next, we're going to go to Anna.
Hi, I'm Anna McAllister. I'm 5'10". I have blonde hair, blue eyes. I'm wearing a black dress, and I'm really pale and white. I feel like I'm describing a prospective date. It's like, look for the chick at the bar that looks like. Anyway, so why am I here? I'll give you a little bit of context for how somebody like me ends up in a meeting like this. I have type 1 diabetes. I've always had very difficult to control glucose. As a result, I have all the complications from diabetes. I have eye disease, nerve disease, kidney disease. I've lived with that for many years. As a result, I think my current count is 13 different medications. I take 13 different medications and use, honestly, I don't even know how many devices, but 2 of them are attached to me 24/7. I have my iPhone, which controls the 2, and an open source. I helped start a patient hacker movement that's built an open source, crowdsourced artificial pancreas system. All of which is to say that I am interested in these issues because I think we absolutely have to have real world evidence to be able to understand the complexity of disease in the real world. So as a result, after starting in economic policy and foreign policy, then getting into healthcare public affairs, about 13 years ago, I co-founded a company to do big data analytics through a visual interface that allowed you to explore what we now call real world data and real world evidence, with the hope of creating what we now call digital biomarkers. The company did not sell to Google or Microsoft, so I'm now doing patient advocacy and focused on data and data use, but it did launch me into this world. From the beginning, I remember coming to Sentinel Initiative meetings back when it was like, should it be distributed? Should it be a centralized database? So I was here and around for quite some time. I was very involved with MD EpiNet in the early days, and am a true believer and supporter for a true believer in Sentinel, true believer in all the efforts for incorporating real-world data and real-world evidence into regulatory decision-making. Having said that, I mean, a couple of things. One, as I have reacquainted myself with where Sentinel is now, I'm impressed in many respects, frustrated in many others. One is we're still relying a lot on claims data. Claims data, like the biomarkers collected in RCTs, is really blunt. It is not subtle. And it makes it easy to analyze and far simpler to analyze, but we need to speed up our efforts to incorporate EHR data. And I'm excited to see that happening. I've seen messy EHR data. I've worked in this space now for 13 years. I know it's super easy to say that and very difficult to do that. So I say that with empathy towards everybody who's been involved in trying to make that happen. But we need to figure out a way to do that, because relying on claims for true signals for things that you may not be expecting isn't sufficient. Secondly, thinking about this just from a patient perspective, who's nerdy enough to be sitting on a panel for the Sentinel Initiative, there have been a couple of instances in which I have been very frustrated with the inability to get evidence or information about real-world uses of certain products. I was put on a beta blocker a few years ago. I won't give you the horror story of what that created, but it was really impossible for me to find any references to the issues I was experiencing in anything in the US. I finally found some real-world data out of the UK. It was claims data, so I was able to put some pieces together and work with my doctors to figure out what was happening, but it was a significant thing, and I would like to have had a mechanism through which I would have been able to communicate with the FDA to see, is this something that we're seeing? Is there somebody who can check to see if this is real? Now, you can't have 350 million people communicating with FDA, but there won't be 350 million people. And I think the agency really needs to think through communication not as an afterthought, but work on strategies and mechanisms for actively engaging patients and patient communities to identify signals and to validate signals in different ways. And whether they're traditional advocacy groups or online communities, if there are issues that are happening with particular drugs, there are people talking about those now online through both in-person and online communities. And those are the people who are really going to be able to help you engage and dig in and see what's happening in the real world. And I think that might be a far more appropriate and effective mechanism for signal detection than relying on MedWatch reports. Because I know that some of the issues that I've experienced, I've reported them to MedWatch. I highly doubt my physicians have. I highly doubt it. It's too complicated. And it's not designed for patient input. It's designed for physicians with EHR systems that integrate in some way, or pharma companies. It's not designed to get patient input. So the agency needs to find ways to actively solicit and seek out patient input and think of patients as an, I think, far more effective mechanism of signal detection. And then, one other thing that's frustrated me over the years, and one of the reasons I started doing a lot of advocacy, is that and the agency has gotten better about recognizing this, that the FDA's decisions have a significant impact on who gets access to medications, how it's reimbursed. And many of the risk decisions the FDA has made based off of RCTs, I think need to be revisited. I used to use erythropoietin stimulating agents for chronic disease, for chronic anemia. FDA created a risk guidance document based off of RCTs that I think were not representative of the full patient population. It's never been revisited, and I can no longer get access to what used to be a very effective and important medication for me. there's no way for me as a patient to ask FDA to revisit that. And there's plenty of evidence if you start looking for studies, for patient input and comments on the impact of ESAs and not having ESAs. There's stuff there that could be examined that the agency hasn't bothered to examine. So we need to take a look at which decisions were made based off of RCTs that were designed to tease out complexity and think through how can we use real-world evidence as a much better way of looking at more nuanced outcomes so that we can allow people to have access to medications that can be used safely.
Thanks so much, Anna, for that important perspective. I think that's all now of our non-FDA panelists, so we're going to switch over to our FDA panelists, starting with Trish.
Okay, so my name is Trish Bright. I'm a white female. I'm wearing a green shirt, black blazer. I have longish hair, gold glasses so that I can look down at my notes, look up at the audience. And I will say that my sister told me that she has a picture of me in her kitchen, and she had friends over, and they said, well, we didn't realize you're related to a hippie. So, all right, so I think I'll just start. I heard some really interesting themes, but I imagine we're going to come back there. So I'll just start with a few general comments. We've heard a lot about the Sentinel system, so I'm not going to go in deep to that, but I'm just going to give a few sort of context points that those close to Sentinel will know, but those a little bit farther away may not know. And so, for example, we have a pharmacovigilance team within CEDAR. And they use a lot of approaches and a lot of tools. So when we talk about Sentinel, we're one such tool that's available to that team. And so we serve them in many ways. We also serve our pharmacoepidemiologists and our reviewers in the Office of New Drugs who are looking at new applications. But the pharmacovigilance team also has many other tools in their toolbox. So just so people know that. We also have a commitment to transparency. So those who are less familiar, there is the sentinelinitiative.org website. You can go on there and find all of our work, all of our trainings, that sort of thing. So I want people to know that if they want another resource outside of this meeting. Our CEDAR pharmacoepidemiologists do a lot of work assessing fitness for purpose/use of the analyses, and they're trying to make the best use of the real-world data for real-world evidence. So our pharmacoepidemiologists work very closely with us. And I wanted to mention that FDA has invested a lot in this pharmacoepidemiology and drug safety, as we've been hearing. And from that, we've gleaned a lot of information, both on strengths and limitations. And I think you've been hearing about that all throughout the workshop. It has allowed us to explore and adopt signal identification and signal detection approaches. And it's also helped us to bolster our inferential analysis capabilities. And importantly, in the last 5 years, and you've been hearing about this a lot today too, is that the Innovation Center has been working towards standing up this linked claims EHR system. And we're hoping that strategic use of that system, along with the natural language processing, helps us to address more of the regulatory questions. And the reason why I mention this, even though we've heard it before, is they've spent 5 years, this isn't one project, 5 years coordinating project after project after project after project. We're now hitting year 5, it's all converging together. So a lot of what people have been interested in terms of EHR, that's coming to us when we're getting closer and closer and closer. So huge effort, and I applaud the Innovation Center for that work on that.
Thanks, Trish. So to conclude our opening remarks portion, we'll go to Steve.
Hello, everyone. I'm Steve Anderson. I'm Director for the Office of Biostatistics and Pharmacovigilance. I am a tall, white male, bald, sort of brown hair, gray hair, and brown eyes, and I'm wearing a gray suit. Just kind of reacting to some of the comments, I think, I think you've heard a lot about the successes and a lot about the limitations of, Sentinel and BEST systems. So I think we have a fair amount of work to do, and I think I will say we're not quite done probably with claims systems, although I agree they have a lot of limitations and they're not ideal. But I think for things like vaccines, because I can tell you we're working with EHR systems for other biologic products. When COVID came along, we had to do vaccine work. We had to go back to the claims systems, unfortunately, because they just have 100 million patients, and there's not systems like that comparable for EHR systems. So unfortunately, that's a reality, at least for vaccines. But I agree for other products, we certainly, I think, need to consider and certainly need to do more to bring these other types of systems. And I think you see that's happening at least, but it's not easy, as we can all see. So, for us, I think for claim systems, we're looking at things like Medicare Advantage, which is approaching about 50% of people in the United States have Medicare Advantage that are 65 and over. That switched from several years ago where it was only 25, 30%. And so now we're incorporating that information and those data into our analyses. So that's sort of an important way to boost numbers as far as and power in our data systems. I wanted to mention Medicaid data because we've explored using that for many years. And so I just want to say the one important thing that I sort of focus on with Medicaid data is that there's estimates that 45% of children in the United States are covered by Medicaid in one form or another. And so it's really important if we want to look at those populations to be able to have access to that data. The reality is there's 50 states, so trying to get access to that data in formats that we can use in a systematic way, consistent manner, is challenging. But I think for us that really is something that's important to do because these underserved populations really do deserve to have safety effectiveness of products they're treated with also looked at for them. So the other aspect of this is I do believe, Yogi mentioned, more rapid chart access and extraction. And so we did make that an effort. That was one of the things that I did was really push for that because I think we've got to make at least these systems that are poor at least somewhat as comparable as we can to the rapidity that we get with EHR systems. We've got to be able, as Heather said, to resolve those signals as quickly as possible and adjudicate them. And so we're working on that as well. And you've seen improvements and heard improvements. And then I mentioned sort of integration. A lot of people have talked about the integrated claims EHR data systems, which are powerful. We've been beginning to use those. As I said, we're going to be going back to those because we sort of dropped that work over the last 3 years because of COVID. We obviously saw a huge success with integrating registry data. But I think to Jeff's point, which was very good, which was, so we integrate vaccine data successfully, but there are these other registries like death registries, birth registries, and that data is not there. And like you said, we need to know if somebody died, and we don't know that in many cases at least with our commercial claims data systems. So that's really something I think we have to really focus on as well. I will tell you the story of an experience with IIS systems. And the reality is that we have about 35, maybe, states and jurisdictions covered out of 64. That took us 2 years, and not us. I mean, that means the data partners, the health plans, to do that linkage. And it's not that these things are technically difficult to do. The challenge is that there's other issues. There are the sort of policies, like some states have policies, no, we're not going to share that outside the state. There are laws that say they can't share those data with health plans, and on and on. And so I think we have policy barriers, legal barriers. So, and I will say that to do those 35 IISs, there was numerous negotiations with 3 data partners separately doing it. So we took a one-off approach where they each did it individually. And you can just do the multiplication, and it's probably over 100 data use agreements that you need to draft in order to get access to that data. So that's not really sustainable. It costs, as Jeff said, a lot of money and a lot of resources to get that. So I think, things are probably going to have to change as far as the laws in order to have access to these data too. And so I think that that's an important thing. So, and then again, I just wanted to emphasize, I've talked a lot about vaccines, and you're probably tired of hearing that. But, the next thing for biologics really is also gene therapies. And so, and I can think of, we have to monitor adverse effects for many of those products. There's generally imposed, a 15-year follow-up period by which sponsors are mandated to do the follow-up on and report any adverse events. And so I think we're going to have to rely on things like registries. The general turnover in these systems, like Sentinel systems for the health plans, is probably 3 years. So, and maybe longer for some of these patients with chronic illnesses. But again, that's a challenge that we're also going to have to think about, is how to, we've heard a lot about registries from Denitsa as well, and so, but how do we really gather the data that we need that's going to inform us about, adverse clinical outcomes from whether it's, T-cell therapies, therapies to treat sickle cell and other things that are coming online pretty quickly. So I'll stop there, but just some general impressions. Thanks.
Thanks, Steve, and thanks again to all of our panelists for kicking us off. We're going to go now into discussion for about 20-25 minutes. As a reminder, please use Slido to throw in some questions. But I have a few to get started, although I think we've already started on a lot of them. But I'll start here. In the previous session, they talked a lot about kind of lessons learned during the COVID-19 pandemic and kind of how to adapt from there. I know in the opening remarks, we already touched on other areas where we've learned some lessons over the years, but are there any other kind of opportunities coming out of the COVID-19 pandemic and looking forward to things like figuring out gene therapies and some of these other newer topics that we've touched on, where there are opportunities to leverage Sentinel and improve what Sentinel and related systems are capable of contributing? I'll open that to anyone that wants to try to jump in.
I could maybe make a little bit of a stab at that. I think a huge, maybe missed opportunity, or at least we ran a study that tried to capitalize on this opportunity, which was we have, I think as a nation, underestimated people's interest in being part of the science, right? And you saw that with the overwhelming interest of people joining programs like vSafe, or a study that we ran that was a primary decentralized, remote consenting, electronic consenting, decentralized safety study called HERO. And those studies allowed the nimbleness that these big organizations weren't able to do right off the bat. So they were the first to launch. Our study launched within a week of product approval. If anybody's ever run a commitment pass before, let me just tell you, starting a study within a week of approval is madness. But we did it, and we proved that we could do it, and we enrolled 20,000 people. The long-term, anybody that's ever run a primary data collection study knows that long-term follow-up is difficult for patients. But that's where secondary data can really shine, right? And we're picking up the gap that the secondary data has identified with regards, we know that these people got vaccinated. We asked them. They showed us their little card. But there was no way for us to feed that information back from patients into these systems, right? And that would have really strengthened those systems from the very beginning, and be able to imagine it was us and vSafe doing that, right? Imagine how many extra vaccine records you would have in these secondary data sets that you would then be able to follow up in the long term. So I spoke a little bit about this when we come to the hybrid kind of models. But I think that that's one place that we consistently miss on our public, particularly when we speak in kind of negative ways about vaccine hesitancy or vaccine reluctance or those kinds of pieces, is if we forget that we have a lot of incredible citizens out there that think that this information is so incredibly valuable and they want to share it with us. We talked about pharmacovigilance being more than just one system, and I think you're right. I know in Pfizer, sometimes I make a little bit of a joke that's like, Pfizer will take your report in any way you want to give it, phone, fax, carrier pigeon. But it's true, and we will, and we do, and we act on those quickly. So thinking of ways, creative ways to bring in those populations that want to be supportive, that think it's important, that are the first to receive our products, those can be those early warning signs, those early warning groups. They're the most invested. So
I completely agree. I mean, and that, you know, is consistent with what I was saying about actively seeking out and engaging individuals. I think we saw and patient groups and communities online, especially when you start thinking about gene therapies in the rare disease communities that you know, will be and are impacted by gene therapies, especially as we start moving into CRISPR. I mean, that's where it's going to show up first. And if we saw anything from COVID, is people are more than happy and more than willing to report issues or concerns or signals, whether it's via Twitter or X or whatever it's called now, or Instagram, or, you know, I mean, there are lots of different ways that people want to communicate issues and are communicating issues. It's not through MedWatch. So I think the agency needs to think beyond the traditional methods of engaging patients and focus groups or whatever, but working specifically and meeting people where they are, not expecting them to come to meetings like this.
If I can just piggyback in meeting where people are, I think that's another thing when it comes to the data. When we're talking about things like Sentinel, and we're talking about, hey, there's all these registries and we can't get access to all of them. Let me tell you, there are people out there that have access to all of those things. They have access to the state's immunization registry and the birth registry and the death registry. Instead of waiting for the data to come up to us and focusing and spending 2 years figuring that out, what if we flipped that on its head and instead embedded people with our skill sets in the places that already have the access? So you're not spending 2 years working with the legal departments before you can ever do the science. You're putting the scientists in the place where they have access, and the work is incredibly valuable to guiding response at a local level.
That's, I think, wonderful ideas and suggestions there. Moving on to an audience question. Throughout the workshop, we've heard speakers focus on pregnancy and pediatrics. We just heard a couple panelists talk about cell and gene therapy, but any thoughts on what will be the next big population to focus, or the next disease area that needs focus of initiatives like Sentinel?
So I'm not sure if you mean above and beyond pediatrics or in pregnancy?
Yeah, I think beyond those. I think, yeah, we heard about those today. So are there others that may warrant kind of an increased level of focus?
Well, I have an array of ideas, but...
Go ahead.
I mean, one of the things that I would like to see Sentinel do, or see the agency do with Sentinel or other tools that it may have, is to look beyond risk and death and you know, harm that medications can do, which is real and important, and you know, that's part of what this is all about. That's, you know, primarily what this is all about. But also look at what are some benefits that may not have been realized, and don't just rely on pharma companies to cough up that science, because it really isn't about the pharma companies. It's about the people that are using the drugs that are produced by the pharma companies. So again, like, I'll just use my personal case study of erythropoietin stimulating agents. You know, there are other things beyond death that should be considered in evaluating risk and safety and efficacy. And all of that stuff is missed because of an over-focus on harm or potential signals for harm. So what are the signals that are counter to harm that are also in the data that may be a little less nuanced or a little more nuanced than what you can actually find in claims? That, to me, is the promise of real-world evidence, is looking at the messiness and finding ways to tease out the confounders to identify which group is really at risk and which group is there a little bit of a risk but a whole lot of benefit. so that the decisions can be made appropriately for individuals, as opposed to having these blunt, please don't use this medication unless the person's ready to have blood transfusion, which is where we are with this class of drugs that has helped millions of people prior to the FDA's risk guidance.
I think, Steve, did you want to weigh in on that question?
Yeah,
too?
so I think for us, as far as, and lessons learned from COVID were just focusing, I think, as well on, other populations like the immunocompromised or persons with immunocompromising conditions. And so, there were recommendations, that they should receive an extra booster dose at certain times with some of the various formulations of COVID vaccine. The other aspect of that, too, is just immune response. Their immune responses are really generally more suppressed or more challenged. And again, so just knowing about vaccine effectiveness and understanding that in these populations, I think would be something that would be important. It's just, as we're going down and trying to do studies again, it is a challenging population to study. And then again, it's just resource intensive to start going down and looking at these populations. And then, the other one is people with comorbidities, with heart disease and other conditions as well. So they're gonna, they're gonna react to vaccines or other products differently. And so I would just throw those out there. And comorbidities is a lot of things. So, but yeah, so there are definitely other populations,
Absolutely.
subpopulations.
I'd like to add to that.
Let's do, Phil, let's go to you.
Thanks. I just briefly, I'll put a plug in. I think the issue that the panelists raised about the benefits that might be, unroofed, so to speak, by real-world evidence. We made decisions about use of paclitax or coated angioplasty balloons based on studies that sterile, randomized clinical trials in non-real-world settings based on a couple hundred patients. But yet our registry, collects data on thousands of patients treated with those devices every month. So there is a huge opportunity to see which patients may or may not benefit and try to isolate factors that would predict success as well as failure. So I'm enthusiastic for the role of longitudinal evaluation using real-world evidence in the cardiovascular device space. It's been work that I've been excited to do for quite some time. And I think as we get better with data collection and data modeling, I think we'll accomplish many of those goals.
Thanks, Phil.
So I think that we maybe need to take a step back and think about real-world evidence in the context of the full ecosystem of evidence being generated around products. And the populations that we need to generate information in the real-world space are the places where they're not well covered in the interventional space. And so I think some of those pieces are going to be around populations that are actively excluded oftentimes from interventional clinical trials, like pediatrics and pregnancy. But it also needs to be in the space of rare outcomes. So places where an interventional clinical trial, even if it's fantastically enrolled, will never be able to generate really great information on either effectiveness or safety. And those could be things like Guillain-Barré syndrome, where it's 1 in 100,000, right? I think that if we take a thoughtful approach to that and we think of real-world evidence as picking up the baton from interventional clinical trials as the next step of the relay race, it's got to run its own race. It can't just duplicate what was already done in the interventional space. And I think there is room to strengthen the interventional space, right? Just like we're talking about strengthening the non-interventional space. So those are a couple places. It's not a slam dunk, here's the population, but here's where I would go. These are the questions I would ask myself in thinking about which populations for which product and at what time.
That's something I think about a lot at Margolis. But Jeff, I think you wanted to weigh in.
Yeah, so I guess I've been doing this long enough that I can't give up the opportunity to, I'm going backwards. There are policy and legal barriers to us doing the work. And we're doing some of this with a hand tied behind our back, and those are things that can be solved, right? It's not a technology problem, and it has to be highlighted. And I think another thing is collaboration. I'll just mention, in the beginning of COVID, all the companies wanted to collaborate. Everyone was trying to figure out a way to do things together because everyone was worried we're all going to have to do the same studies separately. And I don't think there was ever really a good avenue for it. I think that's also a hard thing for the regulator to do. I've never been a regulator, but like for a regulator to do with a group of companies, where do you find the space to talk it through? We're all running through the same problem. Like, I was getting the calls every day. Like, how are we going to do this? How are we going to do this? It was all the same calls. So there was Reagan-Udall tried to bring people together, but there's got to be a space, a safe space, where there can be like real collaboration. And the last thing for unique cohorts, rare disease and ultra rare disease are a real problem in this kind of work, right? I got a really big database. Sentinel's got a really big database. We're gonna have to find ways to collaborate and deal with things where it's, I got 10 people, I got 20 people, right? And that's the whole cohort. What am I supposed to do? And you have to think about that differently than the weight loss drug, whatever it might be, right? And we're seeing more and more of really targeted rare disease, or I'll just say products targeted for very small groups, right?
So to your first point, if you want to know where we are now, I can speak to this a little bit because I'm one of the founding members of it, but we have a group under IFPMA that is the Become group, and I've seen a lot of friendly faces here that I've seen before on that are helping tackle some of those concerns and working with other groups to connect even more. And to the second piece about consortiums, I love the idea of consortiums, and the efficiency in them sounds great. You know when it's not great? When you're first to market. Because you can't wait. It's not right for patients to wait until there are 4 more products on market to figure out if your product is safe or not. So you can't wait for the consortiums, and you have to go it alone. And so there's always going to be a room for us. There has to be a room for us to go it alone where it makes sense to put patients first.
Great discussion. We're running a little short on time. I have a couple more audience questions and then one more I want to ask, and then that probably gets us close to the end. And I think, Jeff, you may have been peeking at my tablet because the first question you already started trying to answer. So we haven't heard much today on industry and FDA partnership to access or use Sentinel. Are there opportunities to increase the ability of industry to leverage Sentinel to answer some of these questions that we're talking about?
It's funny, this question's asked every year, and I was always really happy I wasn't answering. So the resources that FDA has funded here have been used by the rest of the US community and world community. I don't think it's not going to go through FDA to do those, but Pfizer does studies that take advantage of the Sentinel infrastructure, and many other companies do the same thing. They do it separately. It's a parallel approach. I did write a paper on this. So we did publish pretty recently, maybe a year ago, with folks at FDA kind of describing all these other uses. So the investment is being used. There's no easy way to do it. It's still expensive, and you still need good epidemiologists. You still need someone to run the projects for you. But the data are there. The data can be used by others as long as you engage with the data partners to do it. So it's a huge advantage to use that data set, that data source.
I would just throw in that the Reagan-Udall Foundation does have access through IMEDS to some of the Sentinel data, so people can reach out to Reagan-Udall.
Yeah, thank you. Yeah, that's one of the really important ones.
Yes, good flag, Trish. Thank you. Okay, we talked a little bit about, oh, sorry, Steve, go ahead.
I was just pointing at Susan. So go. I think the best route is really go through Reagan-Udall. You could also go through, other sources too, directly to sources as well. So, like, I won't name the specific contractors or anything, but you can do that as well.
Phil, did you want to weigh in on that one?
No, that's okay. I'll let you get to your next question. Thank you, though.
So we've talked a little bit here about the ideas of getting other types of outcomes. So there's a question from the audience on are there points where Sentinel could work more with, say, something like PecorNet, which is focused on getting patient outcomes to kind of supplement what's available? Any thoughts on that? Phil, go for it.
You know, I'm glad that this issue's been brought up. We've tried, you know, and there were points earlier about, you know, very technologically avid patients who quickly engaged with studies that had, you know, online consenting and, you know, very rapid, you know, sort of tune-up. Our patients of vascular surgery, those with many of the worst troubles and probably the biggest gains to make are often those that are the least technologically connected. And we've tried to make ways to make data entry simple, you know, that remote platforms can still be used by some of those populations. And, you know, while I'd be curious for some of the other panelists who I'm sure, you know, similar populations and similar troubles. But we're always alert for opportunities for disseminated data collection that can be scaled to the sort of U.S. News and World Report level, you know, for ultimate simplicity, because you know, many of those patients that were impacted by COVID just didn't seek care at all, you know, and were left, and many times in care desert, so to speak. So while we have that mechanism in place for many of the diseases we treat, we still, I think, have room to go there. So I don't know if anybody had successes that they wanted to share.
If I could just say, we have done some collaborations with PCORnet. So if people are interested in that, you could go to the Sentinel Initiative website and put PCORnet in there. And I would also say that the Catalyst work is interesting, and Dr. Bradley, who's with us, is now working with the Office of Medical Policy, and they've done some work trying to get consenting and things like that, working through the Sentinel system. So that's another thing people might be interested in. But I would say that beyond that, what I'm hearing is that it would be helpful to have more collaboration, more input about patient benefits, patient outcomes. And I think we do have, within FDA, we do have a group that focuses on patient outcomes. And so maybe we have to have more conversations with that group. And I want to point out this is a stakeholder reflections. So it's not so much that FDA, we're telling people, but we're listening. So we are hearing you.
Thanks, Trish. Okay, last few minutes. One more question to give everyone a chance to kind of have one last word. So what do you see as the biggest opportunity for the Sentinel Initiative going into the future? Or what would you like to see from Sentinel going into the future? Anyone want to start?
Sure, I can jump in. I think one of the things that would really speed up safety insights is having rapid validation of the data in these real-world data sources. And I think right now we're still thinking of it in a very sequential manner where you identify the cases, and then you go back to the cases, and then you validate the outcome and the exposure at the same time. If you flip that a little bit on its model, on its head, and instead you said, what does rare disease surveillance look like, and how can we stratify that by exposure? You could validate a lot of the outcomes before you ever need them. And then you go back and you're only validating the exposure at the end, so you can decouple the sequential nature of some of this work and move it in parallel in a way that could really speed up those final comparative reports that we spend a lot of time writing and submitting, and that you all spend a lot of time reading, I'm sure. So I think bringing in the kind, and I heard, I can't remember the name of the person, but the concept of like AI-assisted or intelligent automative assisted validation of those kinds of reports using electronic health records with a, whatever you want to call it, surveillance case definition, clinical phenotype, and the case definitions already exist, right? Brighton's already put 50 of them together for vaccines. That's something that to me is low-hanging fruit at this point. We should be able to do that even with the humans that we have available, and we should be able to start automating that much more quickly. So that's where I'd like to see some effort.
Thanks.
I'm sorry, some effort makes it sound like there's no effort being done, and I know that that's not the case. That's what I'd like to see be amplified.
Thanks. Phil?
Yeah, I'll be brief. I think, you know, continued direction for both industry manufacturers as well as academic research organizations and those who evaluate the performance of cardiovascular interventions about what role real-world evidence will have in device approval and then ongoing device surveillance. So making clear like where a clinical trial would be necessary, but also making it clear where evidence from real-world data sources would also fill in gaps, both in terms of improving the device initially, as well as keeping the device on or off the market in the future. I think the more experience we have with those types of studies, the better that we'll be able to implement that type of evidence in the future. Thank you.
Thank you. Jeff?
Sure. Yeah. So I'll go. I got three things. I think it's data sources, the expansion, the continued work on new data sources, methods, and I think predictability or making, whether it's surveillance or signal refinement, making it a little more expected or routine within a framework. Products like this are going to go this way. Products like that in these kind of areas are going to go here. So, and I believe there's work in that space, but a little bit, if I think if the public saw that really helps public confidence. Like it's on the market and it's obvious what we're doing. I know all the work's going on in the background. The company's doing it and FDA's doing it. But I think if it was clear, like this is what we do and this is how we're doing it, and you can show that on the public websites and things, I think it helps. It'll help public confidence, and it's doable. It's doable today with some money. How's that?
Anna, any thoughts?
Well, I mean, I've mentioned them primarily already, but one is you've got to actively engage with patients where they are and see patients as an asset for signal detection. It's a much faster way than looking for claims data, waiting on reports to trickle their way up through MedWatch, because no patients use MedWatch. And I have serious doubts about how many physicians actually report adverse events through MedWatch. It's too clumsy. And then, also just think more expansively about what are the uses that could be made of Sentinel beyond looking at risk and death. What are the benefits? What are the nuanced cost benefits that you get, whether you're talking about ESAs or, I've been a member of MDAC for 4 years, and, what was started as phase 4 requirements looking at cardiovascular risk for type 2 diabetes medications is now like, hey, these things are really good for certain things that we didn't think they were going to be good for, and that label has expanded. So like, what are those kinds of things that could be done without mandating a phase 4 study that costs, millions and millions of dollars?
Thanks. Trish or Steve, any last words you want to get in before we wrap this panel up?
The one thing that I would just sort of say as an opportunity, which is really a challenging opportunity, I think is to Heather's point and others on Be Safe. I thought that was an extremely, effective program, and it was actually just, quite good the way that it was executed and to get that patient input. And then there's other sort of benefits of doing that, and I think just, that was applied in the vaccine space, but applying that in the rare disease space, because we have an app that we've started to develop in that space too, working with NORD and others, National Organization of Rare Diseases, to kind of use those apps and then try to, you can develop registries through those, you can develop patient questionnaires on new therapies, et cetera. So I think that those are something that, probably need consideration as we're sort of moving ahead in the future, because I think they're potentially powerful tools, especially for certain diseases and outcomes.
And so with a couple of the comments, we hear people say, well, we know what's going on, but you really have to be overt about it. And you're right, because I can see both sides of the fence. I know what's going on. But yes, so I think one of the things we're hearing is some of these issues that people have raised is maybe we need to be more overt in kind of describing the work's going on and how things happen, and to get that word out there.
Okay, thank you all for a fantastic panel discussion to conclude our meeting today. I'm going to hand it back to Garrett to close out the day and get us out of here. Thanks again.
Thank you.
Thanks again to everyone, all of our participants who contributed today. I will be succinct but hopefully poignant in my closeout. We've heard a lot today about many successes of the Sentinel Initiative, from EHR, claims, and also device data, which is a great contribution to have. We can truly see the impact of Sentinel initiatives, analyses, studies, etc. Panelists highlighted the successes of best ISS linkage and the key insights there for vaccine studies, helping to identify vaccinations administered, and all sorts of other associated critical inputs. We also heard about the Sentinel System's efforts to leverage EHR data, such as integrating EHR and claims data, claims linked data into their analyses as part of the 5-year strategic plan. And the Sentinel workshop to start the day, we had a session where we heard specifically from our international regulators on their use of distributed data network systems, including Health Canada, which uses FDA Common Data Model, but also Darwin EU, which conducts analyses using data which spans numerous countries, as you all know. We also learned about FDA's work with ICH and ICMRA. In our final session of the day, we had the opportunity to hear from stakeholders who discussed a variety of topics, including how to make data more accessible for analyses and creating a feedback loop where longitudinal data can be collected and fed into data sets. We've also heard about the need to continue to bolster and link data sets, whether it be HR data, claims data, and death registries, which will assist in finding new signals. And yes, gaps exist and growth is needed. Thanks for never letting up. We're excited to see what the Sentinel Initiative has in store for us next year. Before we go, a brief moment to offer thanks to everybody involved in putting this excellent and work-intensive event together. First of all, obviously, our speakers and panelists who shared their work as well as their insights. We covered a lot of impressive developments and milestones achieved over the past year. Everything talked about today builds upon tens of thousands of hours of work over the 365 days in between meetings. We never lose sight of that and are grateful. Please, again, don't let up. Also would like to thank our colleagues on the FDA planning team. You all don't see the behind-the-scenes efforts of folks like Lucia Menamgusi, Captain Jamila Emwodow, Krista Smith, Angela Moy. We spend so much time with them over months. Also, so many other folks. Thank you. More front and center, of course, we're all familiar with seeing and very grateful for Bob Ball, Steve Anderson, Rich Forshee, Denitsa Marinatz-Beach. Thank you all so much. And, of course, our great team here at Duke Margolis. Our moderators today were Mark McClellan, Rachel Hendricks-Stirrup, Christina Silcox, and Trevin Locke. Thank you so much for making the time as well. All of this is outside of everybody's day job, everyone that's been mentioned so far. And I always like to conclude with, you don't see them. They are so excellent. They make this happen. Our incredible project staff, for this one it was Valerie Parker, Kristen Potziad, Aaron Soul, and Luc Duracher. So grateful for everything you do. And then last but certainly not least, everybody who attended, whether it be here at the National Press Club or virtually, your inputs throughout the day were evident. Thank you so much. Can't do it without you. You have the same level of importance as anybody else. Have a great evening. See you next year.